First of all, I like to greet everyone in the area of World Heart Day. It is 29 September today, and I like everybody to stay safe and be healthy and healthy life. Our 2020, our World Heart Day slogan is "Use heart to beat cardiovascular disease." Today, I will talk about a disease called Cor Pulmonale. It's not a pure cardiac disease. Rather, it has some cardiac manifestation of some other disease, particularly the, the respiratory disease, which affect our cardiovascular system. So it's a multidisciplinary approach for treatment and evaluation of cor pulmonale. Cor pulmonale is a Latin word that means pulmonary heart. Its definition varies, and presently there is no consensual definition. But we should bear in mind that cor pulmonale is the right heart failure caused by chronic pulmonary arterial hypertension. There is an alternation in the structure and function of the right ventricle caused by a primary disorder of the respiratory system. Right-sided ventricular disease caused by a primary abnormality of left side of the heart or congenital heart disease is not considered cor pulmonale. So left-sided heart disease or congenital heart disease which causes pulmonary hypertension and right ventricular dysfunction is not considered cor pulmonale. Although cor pulmonale commonly has a chronic and slowly progressive course, acute onset or worsening cor pulmonale with life-threatening complication can occur. Massive pulmonary embolism is the most common cause of acute cor pulmonale. Now, pathophysiology. Lung disorder causes pulmonary hypertension by several mechanisms, like loss of capillary bed in case of chronic obstructive pulmonary disease and thrombosis in case of pulmonary embolism, vasoconstriction caused by hypoxia, hypercapnia, or both, increased alveolar pressure in case of COPD or during mechanical ventilation, medial hypertrophy of arteriole, often in response to pulmonary hypertension. Pulmonary hypertension increase afterload on the right ventricle, resulting in a cascade of events that is similar to what occurs in left ventricular failure, including elevated and diastolic and central venous pressure and ventricular hypertrophy and dilatation. Demand on the right ventricle may be intensified by increased blood viscosity due to hypoxia-induced polycythemia. Rarely, right ventricular failure affects the left ventricle if a dysfunctional septum bulges into the left ventricle, interfering with the filling and thus causing diastolic dysfunction of left side of the heart. If you look some etiology from pulmonary hypertension due to respiratory disease, these are obstructive lung disease, most commonly chronic obstructive pulmonary disease, cystic fibrosis, bronchiectasis, and asthma and bronchiolitis obliterans. In restrictive lung disease, kyphoscoliosis, pneumoconiasis, connective tissue disease, idiopathic interstitial pulmonary fibrosis is the most common. Others are sarcoidosis, drug-related lung disease, extensive allergic alveolitis, thoracoplasty, sequelae of pulmonary tuberculosis, and neuromuscular disease. Some central origin of respiratory insufficiency, central alveolar hypoventilation, obesity-related hypoventilation syndrome. Previously, it was called Picocian syndrome and sleep apnea syndrome. These are the respiratory etiology of pulmonary hypertension, which leads to cor pulmonale. Several different pathophysiological mechanisms can lead to pulmonary hypertension and subsequent to cor pulmonale. The World Health Organization have 5 classifications of pulmonary hypertension. All except one, that is group 2, is not included in cor pulmonale. If you look the Dana point classification of pulmonary hypertension, you can see the group 1 to group 5. Group 1, this is pulmonary arterial hypertension. It may be idiopathic, may be heritable. This idiopathic and heritable is commonly called primary pulmonary hypertension. Others causes are drugs and toxin associated with connective tissue disease, HIV, portal hypertension, congenital heart disease, schistosomiasis, chronic hemolytic anemia, persistent hypertension of pulmonary hypertension of newborn. Group 2 is due to systolic, diastolic, or diastolic dysfunction of the left ventricle and valvular heart disease. It is not included in Cor Pulmonale. Group 2 is not included in Cor Pulmonale as well as congenital heart disease. Group 3 is the most common cause of pulmonary hypertension. This is pulmonary hypertension because of lung disease and or hypoxemia. It is the main cause of Cor Pulmonale. It is caused by COPD, interstitial lung disease, mixed obstructive and restrictive lung disease, sleep-related disorder, alveolar hypoventilation syndrome. Group 4 is chronic thromboembolic pulmonary hypertension. Group 5 is pulmonary hypertension is unclear and or multifactorial mechanism. Now, as we know, Cor Pulmonale is a chronic, slowly progressive disease. Acute Cor Pulmonale can be occur due to pulmonary embolism. Massive pulmonary embolism is the most common, and other is acute respiratory distress syndrome. When ARDS patient is going to mechanical ventilation, this patient can develop Cor Pulmonale in ICU. Next, epidemiology of Cor Pulmonale. Cor Pulmonale is estimated to account 6 to 7% of all types of adult heart disease in the United States, with chronic obstructive pulmonary disease is account for more than 50% of cases. Mortality in patients with concurrent COPD and Cor Pulmonale is higher than in patients with COPD alone. Globally, the incidence of Cor Pulmonale varies widely among countries, depending on the prevalence of cigarette smoking, air pollution, and other risk factors of various lung disease. Now, how patient of Cor Pulmonale present? Clinically, Cor Pulmonale may be non-specific presentation. Symptom may be subtle, especially in the early stage of the disease. And patient may experience fatigue, combination of fatigue, tachypnea, exertional dyspnea, and cough. Angina chest pain may occur. It may be due to right ventricular ischemia or pulmonary artery stretching. And some neurological symptom may be seen due to hypoxemia, chronic hypoxemia, and reduced cardiac output. Now, sign of Cor Pulmonale. Sign depends on various factors because there is lung disease, pulmonary hypertension, right ventricular hypertrophy, and RV failure. All these disease sign you can find. An increase in chest diameter, labored respiratory effort with retraction of the chest wall, central cyanosis, tachycardia, raised ABP with prominent ANV wave, right ventricular heave, loud pulmonary component of second earth sound, pensystolic murmur of tricuspid regurgitation, early diastolic murmur, early diastolic murmur of pulmonary regurgitation called murmur, hepatomegaly. It may be pulsatile due to tricuspid regurgitation. There may be edema and ascites. On auscultation of the chest, wheeze and crackles may be heard as a sign of underlying lung disease. Percussion of the lung may reveal hyperresonance if the patient has COPD. Now, how we can diagnose? Diagnosis has two parts. One is we have to diagnose the patient as a Cor Pulmonale. We have to investigate its etiology. For diagnosis, we should do some routine laboratory test, full blood count, hemoglobin percentage, hematocrit, arterial blood gas, chest X-ray, ECG, and echocardiography. Once diagnosis of Cor Pulmonale is made, it should be followed by further investigation to determine the underlying lung. Sometimes a common lung disease, that is chronic obstructive pulmonary disease, is not only the only lung pathology. There could be other lung pathology may coexist. So pulmonary function test may be required, as like ventilation perfusion scan and CT scan of the chest. In specific situation, appropriate laboratory studies may be included, including hematocrit to see for whether polycythemia. Polycythemia may be due to sequelae of underlying lung disease, or it may causes pulmonary hypertension, like polycythemia rubra vera. It causes increased pulmonary arterial pressure because there is increased viscosity of the blood. Serum alpha-1 antitrypsin level, antinuclear antibody, anti-centimere antibody for connective tissue disease evaluation, and coagulation studies to evaluate hypercoagulable state like serum level of protein S, protein C, antithrombin 3, factor V Leiden, anticardiolipin antibody, and serum homocysteine level. We should sometime we will look for some biomarker, not only for diagnosis of the disease, but there is some prognostic implication. These are serum uric acid level, which can be increased in patient with idiopathic pulmonary arterial hypertension, and brain natriuretic factor (BNP), which also be used to monitor response to therapy or clinical course, as those with persistently elevated level have worse outcome. Another thing is that 6-minute walk test. It is a non-invasive test. It is easily done and routinely. You can done routinely in your clinic in follow-up visit, or to diagnose, or if you suspect any clinical deterioration, and you can use this to assess response to therapy. A 6-minute walk distance less than 332 meters and drop of oxygen saturation by more than 10% are suggestive of poor prognosis. Now, we should look for some common investigation which we are doing, like chest X-ray. In patient with chronic cor pulmonale, the chest radiograph may show enlargement of the central pulmonary arteries with oligemic peripheral lung fluid. The pulmonary hypertension should be suspected when right descending pulmonary artery is larger than 16 millimeter in diameter and left pulmonary artery is larger than 18 millimeter in diameter. Right ventricular enlargement leads to an increase in transverse diameter of the heart shadow to the right on the PA view and filling of the retrosternal space on the lateral view. These findings have reduced sensitivity in presence of hyposcoliosis or hyperinflated lung. Now, ECG. ECG, there is several abnormality in cor pulmonale. There's reflecting the underlying right ventricular hypertrophy, right ventricular stain, underlying pulmonary disease. These are right axis deviation, RS amplitude ratio in V1 greater than 1, RS amplitude ratio in B6 less than 1, P pulmonale in case of inferior lead 2-3 ABF, and in case of acute cor pulmonale, you may find S1QT3 pattern with complete or incomplete right bundle bound block. And low voltage QRS complex you will find in case of COPD and hyperinflation of lung due to lung disease. Additionally, many rhythm disturbance may be present in chronic cor pulmonale patient. These are isolated premature atrial contraction, various supraventricular tachycardia, including paroxysmal atrial tachycardia, multifocal atrial tachycardia, we can sometimes call it METS, atrial fibrillation, atrial flutter, junctional tachycardia. These arrhythmia may be triggered by process secondary to underlying disease like anxiety, hypoxemia, acid-base imbalance, electrolyte disturbance, excessive use of bronchodilator, but life-threatening ventricular tachycardia are less common. If you look for echocardiography, it is one of the main diagnostic modality to diagnose cor pulmonale. There you can find right atrium and right ventricle dilatation, flattening of the interventricular septum with D-shaped left ventricle, increase right ventricular wall thickness, dilatation of the pulmonary arteries. Doppler study you can find and you can estimate pulmonary artery pressure, there is pulmonary artery systolic pressure. And you also look for, as well as right ventricular anatomy, you should look for right ventricular function also. You can be assessed by echocardiography by doing tricuspid annular plane systolic excursion, that is TAPSE. You can use right ventricular stain, longitudinal stain. You can use to see right ventricular function. You can see right ventricular function by calculating myocardial perfusion index. Myocardial perfusion index can be calculated by isometric relaxation time and contraction time divided by ejection time. Higher myocardial perfusion index indicate greater RV dysfunction, and it has advantage that it is independent of right ventricular chamber size and geometry. If you suspect the patient has pulmonary thromboembolic disease, uh, then in case of acute pulmonary embolism, if you suspect which causes Cor Pulmonale, you should do a CT pulmonary angiogram. And if you suspect chronic pulmonary thromboembolic disease, which can lead to pulmonary hypertension and Cor Pulmonale, at that case, the CT angiogram is not preferred. Ventilation perfusion scan is the choice of investigation in case of chronic thromboembolic pulmonary hypertension. You will find there is perfusion defect in case of normal ventilatory function. And the cardiac catheterization. Cardiac catheterization is a gold standard for assessment of pulmonary hypertension, but routinely it is not done because nowadays high resolution echocardiography and if in advanced center magnetic resonance imaging, that is CMR, is a good modality to measure pulmonary pressure. But when the echocardiogram cannot assess the severity of tricuspid regurgitant gent, or there is the poor echo window, you can use cardiac catheterization. Another implication of cardiac catheterization is you can assess reversibility of the pulmonary arterial hypertension for your treatment purpose. Treatment model is which type of treatment a patient should get and whether this pulmonary hypertension is reversible or not. Then you can assess reversibility test by cardiac catheterization, right heart catheterization. Next, sometimes as lung disease is the main concern of pulmonary hypertension leading to Cor Pulmonale, lung biopsy is sometimes necessary to determine the exact etiology of underlying lung disease, especially if interstitial lung disease is suspected and its etiology. And it will be necessary for prognosis and management of interstitial lung disease, various type of pneumonia and interstitial lung disease. And we should also look for the differential of Cor Pulmonale, whether the patient has Cor Pulmonale or other kind of disease. The differential of Cor Pulmonale is the congestive heart failure, biventricular failure, constrictive pericarditis, infiltrative cardiomyopathy, pulmonary stenosis, right heart failure due to right ventricular infarction, right heart failure due to congenital heart disease. We should bear in mind of this disease as differential. Now, management of Cor Pulmonale. Medical therapy for chronic Cor Pulmonale is generally focused on treatment of underlying pulmonary disease and improving oxygenation and right ventricular function by increasing right ventricular contractility and decreasing pulmonary vasoconstriction. Oxygen therapy, diuretics, vasodilator, digitalis, theophylline, and anticoagulation therapy all are different modalities used in long-term management of chronic Cor Pulmonale of various etiology. Patient education is very important because it is a solely progressive and chronic course of disease. So patients should be educated regarding the nature of the disease, and he or she should adhere to medical therapy is vital to alleviate the hypoxia of underlying disease. And general measure, mild physical activity via exercise rehabilitation is beneficial. Routine influenza and pneumococcal vaccine. Contraception should be discussed with female of childbearing age because pregnancy causes increased mortality in case of Cor Pulmonale. Oxygen supplementation, exposure to high altitude should be avoided. Diuretics therapy is indicated to manage right ventricular failure with volume overload. Oral anticoagulation is recommended in case of idiopathic pulmonary arterial hypertension and chronic thromboembolic pulmonary hypertension, and INR should be 1.5 to 2. If you look for the group 1 pulmonary arterial hypertension, then these are the treatment algorithm. We should use anticoagulant, diuretics, oxygen, and digoxin if necessary. Then we should go for, in case of group 1 pulmonary arterial hypertension, acute vasoreactive test by cardiac catheterization. Acute vasoreactive test, if it is positive, then we will put the patient to oral calcium channel blocker in the sustained controlled release of nifedipine or diltiazem. Then we should assess his response. If there is sustained response, then we should continue calcium channel blocker. If there is no sustained response, then we should switch to another drug. It is study shows that in case of idiopathic pulmonary arterial hypertension, acute vasoreactive testing shows only 10 to 15% cases it is uh, acute vasoreactive testing is positive. Of 10 to 15% cases, 50% is sustained response. Other 50% do not respond in long term. So after if vasoreactive testing, if it is negative, then we will put the patient in two groups, whether it is low risk or high risk patient. To assess the low risk and high risk patient, you should assess some parameter. The determinant of risk, whether it is high risk or low risk, we should evaluate clinical evaluation of heart failure. There is evidence of heart failure. How it progresses, it is rapidly progressive or slowly progressive disease. 6-minute walk test, BNP level, and echocardiogram finding. By this parameter, you will put the patient into low risk or high risk. If the patient is low risk, you can go for either endothelin receptor antagonist, that is imbisartan, bosentan, or you can go for phosphodiesterase 5 inhibitor, that is sildenafil, tardanafil. It is oral drug. Or you can go for epoprostenol or treprostinil, that is vasodilator, prostaglandin. It is IV or inhale also occur, iloprost or treprost. Or you can use combination of this drug like endothelin receptor antagonist with phosphodiesterase 5 inhibitor. If one type of drug is not responding, then you can do in combination of this. Then assess and consider combination therapy. And in case of high risk patient, you should go for epoprostenol or iloprost inhalation in the first time, and then you can combine antagonist or phosphodiesterase 5 inhibitor oral. In case of high risk patient, you can assess the therapy, and if it is patient is not improving, then you can go for atrial septostomy. It is a balloon atrial septostomy to relieve the right atrial pressure, the right sided pressure, and offloading the right sided pressure to left sided pressure. And ultimately, this patient needs a heart-lung transplantation in case of high-risk patients who are not responding to your drug treatment. It is the algorithm pulmonary arterial hypertension group A. Next, Cor Pulmonale due to lung disease. This treatment is only the underlying cause of lung disease. pulmonary vasodilator are not indicated in case of cor pulmonale due to lung disease, which is the most common cause. So underlying lung disease treatment is the main one, and general measure and judicious use of diuretics and other drug oxygen supplementation. In case of acute pulmonary embolism, which causes cor pulmonale, you can use thrombolytic therapy, tissue plasminogen activator, in case of acute setting with ICU. There are some surgical management of cor pulmonale. If the hematocrit is 65% or more, then the phlebotomy is indicated, and it will be done in hospital setting with saline IV isotonic saline to replenish the volume depletion, and it will be done. Phlebotomy will be done in regular interval by assessment of hematocrit. And ultimately, the heart-lung transplantation is the one surgical option of the end-stage cor pulmonale patient. Should be considered in a subset of eligible patients who remain NYHA class, functional class 3 or 4 after optimal medical therapy. So complication of cor pulmonale is include syncope, hypoxia, pedal edema, passive hepatic congestion, and ultimately death. Now, how we will follow up this patient? Frequency of follow-up depends on clinical course. Those who have stable clinical course, that is, stable clinical course means no evidence of heart failure, normal RB size and function, functional class 1 and 2, 6-minute walk test more than 400 meter, and stable BNP level. The clinic visit should be every 3 to 6 months. Those patients who are unstable, that is, there is sign of right heart failure, 6-minute walk test less than 300 meter, increasing BNP level, or the patient is on frequent IV therapy or combination therapy, clinic visit should be every 1 to 3 months. The prognosis of cor pulmonale is variable depending upon the underlying pathology. Development of cor pulmonale is a result of primary pulmonary disease, usually hurdle the poorer prognosis. For example, patients with chronic COPD who have cor pulmonale have 30% chance of surviving 5 years. Thank you.
স্যার আদাব স্যার, শওকত বলছিলাম স্যার। থ্যাংক ইউ স্যার আপনাকে স্যার, খুব সুন্দর ক্লাস ছিল স্যার। স্যার একটা কোয়েশ্চেন ছিল স্যার, দুইটা টার্ম আমরা খুব শুনি স্যার, একটা হচ্ছে রিভার্সিবিলিটি টেস্ট আর একটা হচ্ছে ভেসোরিঅ্যাক্টিভিটি। রিভার্সিবিলিটি সম্পর্কে মোটামুটি স্যার জানি, ভেসোরিঅ্যাক্টিভিটি টেস্টের স্যার ইন্টারপ্রিটেশনটা মানে কিভাবে করি, কখন পজিটিভ কখন নেগেটিভ একটু জানতে চাচ্ছিলাম স্যার।
The reversibility test and vasodilativity test. Reversibility test is done in case of pulmonary hypertension for treatment purpose, whether the patient will be response to long-term calcium channel blocker. At that time, right heart catheterization is done and reversibility is assessed by inhaled nitric oxide along with prostaglandin. And the reversibility, we should call this reversible when the pulmonary hypertension is less than, if pulmonary hypertension decreased more than 10 millimeter of mercury, and ultimately mean pulmonary artery pressure should be less than 40 millimeter of mercury. Like if a patient has mean pulmonary artery pressure is 48 millimeter of mercury, and reversibility test shows that it is 38 millimeter of mercury, then it is positive response, that is reversible, because the from 48 to 30 it is 10 or more than 10, and ultimately it has more than 40, less than 40 mean pulmonary arterial. Mean pulmonary arterial pressure should be less than 40 by reducing the pulmonary artery pressure 10 millimeter mercury. Another example is that if any patient has pulmonary arterial pressure is 60 millimeter mercury, but in reversible testing it decreased pulmonary arterial pressure 15 millimeter mercury. But this is not the positive response, because 15 less than 60 is only 45. It does not reduce less than 40, so it is not reversible, though it decreases pulmonary artery pressure more than 10. So two criteria should be fulfilled to reversibility assessment whether it is positive. One criteria is the pulmonary arterial pressure should be less than 40 millimeter mercury ultimately, and decrease of pulmonary arterial pressure should be more than 10. মানে 10 কমতে হবে, 10 কমে pulmonary arterial pressure 40 নিচে নামতে হবে। যদি 15 কমে
10-20%, 10 কি স্যার 10%?
না 10 10 মিলিমিটার মার্কারি। পালমোনারি আর্টারি প্রেসার 10 মিলিমিটার মার্কারি কমতে হবে, কমে তার পালমোনারি আর্টারি প্রেসার 40 নিচে নামতে হবে। যদি একজনের পালমোনারি আর্টারি প্রেসার 10 এর বেশি কমলো, লাইক 15 কমলো বা 18 কমলো, কিন্তু আলটিমেটলি তার পালমোনারি আর্টারি প্রেসার কমে 40 এর নিচে আসে, তাহলে পজিটিভ বলা যাবে না, তাহলে পজিটিভ হবে না। ইট ইজ নট পজিটিভ রিভার্সিবল টেস্ট। কারো পালমোনারি আর্টারি প্রেসার আছে 65, রিভার্সিবিলিটি টেস্টে দেখা গেল ব্যাথোরিয়েক্টিভ টেস্ট, নট রিভার্সিবিলিটি টেস্ট, ব্যাথোরিয়েক্টিভ টেস্টে দেখা গেল তার 15 বা 18 মিলিমিটার পালমোনারি কমে গেল।
এটা কি ব্যাথোরিয়েক্টিভ টেস্ট বললেন নাকি রিভার্সিবিলিটি বললেন?
রিভার্সিবিলিটি টেস্ট। নো, ইট ইজ ব্যাথোরিয়েক্টিভ টেস্ট।
ব্যাথোরিয়েক্টিভ।
আর রিভার্সিবিলিটি টেস্ট ইজ ডান ইন কেস অফ হার্ট লাং ট্রান্সপ্লান্টেশন অর লাং ট্রান্সপ্লান্টেশন। যখন একটা পেশেন্টের when a patient is undergoing lung transplantation or heart lung transplantation, at that time we should go for heart transplantation এর ক্ষেত্রে আমরা অ্যাসেস করা হয় যে তার পালমোনারি হাইপারটেনশন যেটা আছে সেটা রিভার্স করবে না রিভার্স করবে না।
স্যার রিভার্সিবিলিটি টেস্ট কি আইবি এডিনোসিন দিয়ে করা যায়?
হ্যাঁ, রিভার্সিবিলিটি টেস্ট আইবি এডিনোসিন in
sorry reactivity test, reactivity test,
reactivity test nitric oxide with prostaglandin, that is IV prostaglandin or IV adenosine combination.
আর একটা কার্ডিয়াক ক্যাথ করে আমাকে স্যার মেজারমেন্ট গুলো নিতে হবে, রাইট সাইড
রিভার্সিবিলিটি টেস্ট। যেটা ইম্পর্টেন্ট হলো দুইটা প্যারামিটার ফুলফিল করতে হবে, 10 মিলিমিটার হতে হবে কমে, সেটা 40 মিলিমিটার
40 এর নিচে আসতে হবে।
15 মিলিমিটার কমলো কিন্তু 40 এর নিচে নামে নাই, তাহলে এটা পজিটিভ রিভার্সিবিলিটি টেস্ট হবে না, সে তারা ক্যালসিয়াম চ্যানেল ব্লকারে রেসপন্স করবে না।
আরেকটা স্যার আপনি যেখানে স্যার ওই যে টাইপ 1 মানে ইডিওপ্যাথিক পালমোনারি আর্টেরিয়াল হাইপারটেনশনের ম্যানেজমেন্ট যেটা দেখাইছেন স্যার, এটা কি কর পালমোনারির ক্ষেত্রে প্রযোজ্য হবে স্যার?
হ্যাঁ, যদি কর পালমোনারি ইজ ডিউ টু ইডিওপ্যাথিক পালমোনারি arterial hypertension. Pulmonary hypertension is the main factor which causes cor pulmonale, except group 2 and group 2, that is pulmonary hypertension due to left heart disease or diastolic dysfunction or valvular heart disease. It is not included, it is not called cor pulmonale. Another thing is that congenital heart disease is not causing pulmonary hypertension, and feature of cor pulmonale is not cor pulmonale. So group 2 pulmonary hypertension and pulmonary hypertension due to congenital heart disease is not cor pulmonale. Other disease which causes pulmonary hypertension and ultimately leading to the right heart dysfunction or right heart failure is termed as cor pulmonale. Even neuromuscular disorder, kyphoscoliosis, alveolar hyperventilation syndrome, sleep apnea syndrome, everything can cause cor pulmonale.
আরেকটা স্যার এই যে ইডিওপ্যাথিক পালমোনারি আর্টেরিয়াল হাইপারটেনশন, এখানে স্যার মানে সিভিয়ারিটির উপর ভিত্তি করে কি আমরা ওরাল অ্যান্টিকোয়াগুলেন্ট দিব, নাকি এটা ডায়াগনোসিস হইলেই ওরাল অ্যান্টিকোয়াগুলেন্ট সবাইকে দিয়ে দিবেন?
হ্যাঁ, ইয়েস, One thing is idiopathic pulmonary hypertension. Once diagnosed idiopathic pulmonary hypertension, we should go for oral anticoagulants in the form of warfarin. Or if the patient, another type of patient, this patient is a chronic thromboembolic pulmonary hypertension, then you should go for oral. And if any patient has acute cor pulmonale due to massive pulmonary embolism, he also can be thrombolytic as well as long-term oral anticoagulant depending on the etiology of pulmonary embolism. If the etiology is correctable, then he will get 3 to 6 months of oral anticoagulant. If etiology is not correctable, then go for long-term oral anticoagulant.
Thank you, sir.
Thank you, sir, for your nice presentation.
হ্যাঁ বদরুল, হ্যাঁ বলেন।
আমার একটা সিম্পল একটা কোশ্চেন ছিল স্যার, আমরা ক্লিনিক্যালি কিভাবে কনজেস্টিভ কার্ডিয়াক ফেলিওর থেকে আমরা কিভাবে ডিফারেন্সিয়েট করব কর পালমোনালে?
হ্যাঁ, ক্লিনিক্যালি আপনাকে একটা জিনিসের ডিফারেন্স বিটুইন দ্য congestive, whether it is the right heart failure or biventricular failure. Okay, right heart failure or biventricular failure. So cor pulmonale আমরা সেই পেশেন্টগুলোকে cor pulmonale বলছি যারা রাইট হার্ট ফেলিউর নেই। রাইট হার্ট ফেলিউর আছে, লেফট হার্ট ফেলিউর নাই। লেফট হার্ট ফেলিউর, right heart failure due to left-hearted failure is not cor pulmonale. Group 2 pulmonary hypertension, there is pulmonary hypertension due to left heart disease, is not included in cor pulmonale. Clinically আপনাকে ডিফারেন্সিয়েট করতে গেলে প্রথমে হিস্ট্রি, যে তার আগে কোনো ইসকেমিক হার্ট ডিজিজ or valvular heart disease ছিল কিনা, or there is a possibility of ischemic heart disease or valvular heart disease or cardiomyopathy. History. Then you should go for clinical examination. ক্লিনিক্যাল এক্সামিনেশনে আপনাকে রাইট সাইডের আরেকটা হিস্ট্রি থাকবে। যদি এটা কর পালমোনালে হয়, আপনাকে একটা লং টার্ম হিস্ট্রি অফ রেসপিরেটরি প্রবলেম থাকবে। তার ক্রনিক কফ, সিওপিডি, ক্রনিক অ্যাজমা অর ইন্টারস্টিশিয়াল লাং ডিজিজ থাকবে কর পালমোনালির ফেভারে। এবং আপনি ক্লিনিক্যালি যদি দেখেন তাহলে আপনাকে রাইট সাইডের কার্ডিয়াক ফেলিউরের জন্য রেজ জেবিপি উইথ প্রমিনেন্ট ANC উইথ হেপাটোমেগালি, ascites or peripheral edema, but lungs will be clear, or you can find lungs findings, respiratory findings depends on the etiology. In case of biventricular failure, you will find the bivasal crepitation of pulmonary edema. In case of acute presentation and chronic presentation, you may not find the bivasal crepitation of left heart failure. At that case, you should rely on the history and investigation. Left heart should be normal in cor pulmonale. If there is any abnormality of left heart, think of that it might not be cor pulmonale, it might be due to left heart disease. So investigation, ECG, X-ray, and particularly important is echocardiography. Echographic measurement of left ventricular function is important to diagnose cor pulmonale.
এটা হয় স্যার, যদি কোএক্সিস্টিং ক্রনিক হার্ট ফেলিওর ডিউ টু আইএসডি থাকে সাথে, সেক্ষেত্রে তো স্যার আমাদের একটা সমস্যা হয়ে যায়। একসাথে আইএসডিও আছে, সিওপিডিও আছে।
হ্যাঁ, সেই জন্য আপনাকে, যদি আপনি ওই পেশেন্টটা যে তার আইএসডি আছে, সিওপিডি আছে, এখন তার সিমটম ইজ ডিউ টু cor pulmonale নর আইএসডি, এটার জন্য আপনাকে কার্ডিয়াক ক্যাথ করতে হবে। কার্ডিয়াক ক্যাথ করে আপনাকে দেখতে হবে যে পালমোনারি ক্যাপিলারি ওএস প্রেসার কত আছে। পালমোনারি হাইপারটেনশন আছে, ওকে, but pulmonary hypertension may be due to cor pulmonale, may be due to left heart disease. So you have to assess the pulmonary capillary OS pressure, that is left-sided heart, left atrial pressure, surrogate marker of left atrial pressure. Pulmonary capillary OS pressure যদি আপনি দেখেন যে it is less than 15 mm mercury, most likely the patient has cor pulmonale and it produces symptom. If pulmonary capillary OS pressure is more than 15 mm mercury, it is likely due to left heart disease.